Awesome. Wow, that looks
Here
great.
with Mohammed, and we'll be try and be quick. Pulling up the tail end. I feel like percutaneous screws have gotten incredibly popular recently. Maybe sometimes pushing the indications, but in the right indications, I think it's great. Get your patients moving more quickly, much less invasively. So just some of the tips and tricks that I have learned along the way. When we're looking at, and again, this can be look like some random shapes up here, but when you're looking at the pedicle, this is one of the really important views that you'll see on X-ray. So if we were to go over to the X-ray itself, I don't know if you can see this, but we're looking at kind of an oblong circle shape. Never mind. We'll go back to that later once we're actually using fluoro. But this oblong circle is the AP view of your pedicle. And this is one of the really important views because we want to start lateral to the pedicle when you place your Jamshidi needle. And then as you get medial to the pedicle, you can go past this into the body, but you want to make sure that as you're coming down the pedicle, that the tip of your Jamshidi needle is anterior to the posterior aspect of the vertebral body. So these two views are very important, both this lateral view and this AP view. And you want to kind of, in your mind, have a 3D visualization of coming down the pedicle without violating the canal or skiving laterally. Over here on this side, just showing that one of the things they've seen when they look postoperatively at some of the placement of pedicle screws percutaneously. Sometimes the facet joint can be very transversely oriented opposed to cephalocaudal. And so in these circumstances, the facet joint is very easily violated. So we talk about a 12, 3, and 6 o'clock starting point if we were on the patient's right side. And just to know that maybe you want to start a little bit lower than 3 o'clock if you want to stay completely within the superior articular process and not get into the facet joint, because we could be creating more arthritis if we're just blasting through that facet and we have screw threads inside of it. Another way to visualize this would be kind of on an axial cut and you're in the superior articular process. One of the places you want to start is right up here, and it's very easy to skive off the side. When we do our open surgery, a lot of times we'll be removing this bone and starting with our screw placement right here. So sometimes you have to really start with a more medialization of the screw in order to get into bone and then take your appropriate trajectory. And then one of the last things is you don't want to cut wires. So this is a screw and this is a wire here. Really want to make sure that you're going collinearly, because if you come at an angle like this and the wire is bent, you can break that wire off in the middle of the canal, and then you've got a really tough day ahead of you trying to get that out. So just some of the few things to keep in mind. Again, kind of basics of pedicle screw placement with a percutaneous approach, but if you keep those in mind as you're doing it, you will save yourself a lot of headaches down the road. So we're here with Mohammed. We've got one side already instrumented with the wires, but Mohammed's going to take us through our steps. If we look at the skin, one of the things you do want to do, I was just marking the lateral aspect of the pedicles. Your skin incision is going to be even further lateral to that. Some people choose 5 centimeters away from midline. Some people choose 1 centimeter lateral to their markings. Again, as long as you have a consistent system, but knowing where your skin markings are is going to tell you where the tulip heads are going to be. And if you see that they're very staggered, if there's a lot of abnormality between the vertebrae, one from another, you may want to plan to have a more medial starting point for one and a more lateral starting point for another in order to keep this cascade in line. So go ahead, Mohammed, let's make a skin incision here, and we'll get ready with some screws. All right, so he's staying nicely lateral to the markings, which preoperatively for me, I just like to know where that medial aspect of the lateral pedicle wall is. And one of the things here, we've got C-Spine with us. Thank you very much for helping us out today. We're using their pedicle screw system. One of the things to look at here is I do like to have these beveled tips available, because if you want to adjust your trajectory in the middle of the actual placement of the Jamshidi needle, this allows you some directionality, whereas if you have a kind of diamond point, it doesn't necessarily give you that. And I also like this for getting into that lateral aspect. So if you look at the top, it's got a point, an arrow pointing to where the bevel is going to take you. So go ahead. We'll come to an AP, please. So go ahead and get down on bone. Just find what you think you're going to be on, and then you can feel a little bit there. We'll use our sponge stick holder to avoid radiating our hands. Yeah. Okay, Mom, go ahead and grab that from me. So that looks like a fairly good starting point. We can't see that pedicle especially well. Let's give ourselves a little bit more straight up and down view. And hold on. Yeah, let's hold this here so you're not radiating yourself.
Amir, what do you think about using navigation for MIS?
I think navigation works pretty similarly, whether you're using MIS or not. So, you know, I think it's valuable if you feel like you need it in that circumstance. The MIS versus the open, you know, it's going to be kind of the same system either way. Actually, maybe a little bit more this way. Keep coming down. Okay, give us a shot there. Yeah, that looks better. So I would come a little bit more distal with your starting point. And when I'm doing these cases, I feel like the wire placement is one of the biggest parts. You can see up above the discrepancy between the left and the right sides. One of those is going to be probably a little too straightforward. The other one's probably a little bit too medial lateral. And you really want to avoid problems. I see a lot of misplaced screws with percutaneous screw placement. And taking the time to place a nice wire can really prevent doing that in the future. So that's probably going to be okay. Again, we might want to start with a little bit lower starting point. Let's try that. Okay, and that's going to be lateral. And again, you're having that same struggle where you keep sliding off. Shot there. And that looks pretty good to me.
I know. Mohammed, you're going to have to spend an extra year. We're going to make you repeat the fellowship. Oh, that looks good.
Okay, give yourself a little bit more. And then again, you can turn this, so that's going to take you more cephalad. Okay, keep going.
You're such a good guy, Zach.
And now that you're in bone, you can relax with the sponge stick and kind of be a little bit more aggressive. Shot. And so we're still very well lateral to the medial wall of the pedicle. So we know we're not going to violate the canal. Shot. Now we're right up against the medial aspect of the pedicle. So we'll come to our lateral view. If we find that we're not all the way to the back of the posterior aspect of the vertebral body, we'll have to readjust, take the Jamshidi needle back, and adjust with that bevel. Okay, so we are kind of very, very close there to that medial aspect of the wall and the posterior aspect of the vertebral body. So it's right up against that lateral aspect of the pedicle. So I might back it up just a little bit. I'll turn my bevel the opposite way, and that should skive right off of that pedicle wall. Okay, so, and if we come back just to demonstrate, shot there. So that's the posterior aspect of the pedicle wall. Let's come back to the AP. Or posterior aspect of the vertebral body, so we want to be medial to the pedicle wall. Okay, and that's well medial, but again, we can readjust this pretty well with the bevel tip pointing the opposite way. Shot there. It's going low.
I don't know if I can.
Shot again.
If I don't release.
And come to a lateral, please. Shot. Okay, so now we're well within the body. Let's go ahead and place our wire, and we can use the wire to palpate and make sure that we are in bone. And be careful not to push this wire too far anteriorly. And then we do need a little bit of wag here. So again, it's probably going to be this way. Okay, shot there. Okay, good.
Right now.
So you can, push that down, make sure it's well within bone, and keep that in place as you pull your jam sheeting needle back. And people have different ways of approaching the screw placement. We're going to be using power here. And so one of the things to keep in mind in sclerotic bone, you probably want to tap. We're just going to be going straight into screw placement here. So give us a shot there. Okay, and you can see, again, it can be hard to tell, but I want to stay collinear with my screw. Shot. A little bit of a high starting point on these top screws. Also, another thing is you want to make sure that your fascia is not holding you up. And there, I'm just about to break that. So at this point, I might back it up a little. Shot. Okay, and I'm going to want to pull that wire out. So can I get a, ooh, this is fancy. So and this just locks on. Okay, and so before I break it, I want to pull it back. Now I know I've got my screw in my pedicle. I can go ahead and finish placing the screw. Shot. So that's kind of more of an anatomic type of a trajectory that we've got on that top screw. So let's have you come down to your next one lower, just so we can see that a little bit better. And we'll take a look at some APs. Can we get another screw? Okay.
The lower one is?
Yep. Why don't we come to an AP just to take a look while we're getting our next screw loaded up. Okay. You can see we've got that medial lateral trajectory not crossing midline. Pretty comfortable with that placement. And again, typically when we'll do open screws, we really want to keep that screw medial to midline. It really depends on your trajectory. So if you're starting with a more lateral starting point, it may cross midline. But again, that's going to really depend on the technique you're using for screw placement. Okay, come back to a lateral, please. All right, so bottom is forward, top is backward. And as you come down, you want to keep that trajectory. So I would give myself a shot first. Okay, you can see that your screw is heading in the same direction. Now, and one of the things that can be challenging is you may not know what wire you're on. So I'm going to pull mine back. Shot. So I pulled back the one that's going high. You're the one that's going low. So that's the one you want to be in line with. So go ahead nice and slow. Go forward with the driver. Yeah, very gentle, good. And you'll feel it start to catch bone. Keep going. Okay. And also one of the things, again, we want to make sure that your fascia is open. I should have done this before, just double checking. Go ahead. Yeah. Okay, now, so now you're well within the pedicle. You can probably take this wire out. That will want to bind up on you. Sometimes you can just take it part of the way out. Shot. So now you know you're not stuck, but it's still going to keep you there. Keep going. Okay,
What is it called? The wire?
Shots?
good. And I don't know if this driver does it. Some drivers will allow you to actually manually turn those last couple turns, so you're not plowing too deep. Shot. That's too deep. So
No.
different drivers will give you different tactile feedback. Shot. And one of the things when you're doing percutaneous screw placement, it's very easy to go too deep and strip your screw.
Yeah.
Okay, let's get another one, please. So I'm gonna have you come to this side and do the rest of these that are already placed so we can try and do a passing of a rod. Do you have a head turner? So Mohammed, come over here. So if you want to start from the bottom, do that one. Do you have a hand driver? A hand driver? So we can get more screws loaded? All right, just going to check and make sure that you've got this open fascia here. Okay, nice.
Yeah, that's good. Just take it down.
Yeah. And again, try, I don't know if you can, you really want to be gentle with your pressure. It can go, usually these can go kind of in two different speeds if you bring it halfway down. Keep going.
Shot?
And so this one's nice and free. You're well within the pedicle, so keep going. So I'm going to pull this wire back. Go ahead. All right, now go ahead all the way down.
No way.
It's good there.
That looks pretty good.
Hell no. I wouldn't let anybody.
Yeah, so pull this back,
Hell no.
and then you'll turn this one to disengage it.
Seriously. It's just so much. And you can imagine how strong.
Oh, I know, dude.
Let's get Mohammed set up for his next screw.
If you can't take it, I can't imagine how bad it is if you're. I can't imagine how.
See a shot there? Shot again. And there. Okay, good.
Look at this. Run out of battery.
Shot. Okay.
Yeah. Yeah, for sure.
Shot, please.
A couple little technical things here and there, but other than that, everything seems to go smooth.
So one of the things I like about hand is I can feel when it's starting to get tight. Shot. And I know my appropriate depth. With power, that's something you definitely need to be careful of. Okay, let's do our final screw here. Not sure why we're stuck. Go ahead. Go ahead.
Am I grab it and forget that?
Shot, please.
Okay. So you can see you're very close. You do want to adjust your shot. Yeah. You're good.
Take that.
Mm-hmm. And again, I'm not sure if, see how you can do very slow
Yeah.
forward. That's a powerful technique when you're doing these so that it doesn't drive too deeply on you. Just kind of very slow turn, so you have to use that subtle pressure. Can we get that wire holder?
One shot.
Okay. Okay, go ahead. There you go. That's what we like to see. Shot. Okay, that's a little deep. Or, you know,
Out.
not sure if which screw that is. It looks like, I think you're okay. I think you're okay. Yeah, you're fine. So disconnect here. All right, in this system, they do have a rod passer. So this tool is helpful to clear soft tissue away. So go ahead and grab that. You want to make sure that you're going through each of those tulip heads. So go ahead. I don't know if you how well you can see here.
Then we connect the.
Yep. So you want to remove the soft tissue in between each. See, we've got these all nicely lined up. And sometimes you can actually see down the barrel, so you can see if it's passing. One of the other things you can do is take the head turner and see if it turns freely. You know that the rod is not through it. Good. So good. Can you see that you're in the next one? Yep, that's good. You were in. No, so and you should be able to come all the way through. Yeah.
I went through the.
Yep. So you can see you're there. There's the next one. And then right there, through all of them. So we know we have a passageway that works. We'll take our rod next. Again, this has got a tapered tip, so some people don't use that step. I think that it's nice to be able to make sure that you have a good passageway. So go ahead and grab that. And in the same way, you're just going to look at your heads as you come through each one. I'm just going to check here to make sure that you're captured. Okay, and so I can see this one's freely turning, so I know that one's
Not in.
not in. And sometimes you'll actually need to sit this.
My tip here.
And so if you need help, I can adjust this medially or laterally
Towards.
to help you pass it. Are you happy with that? No, it looks like you're medial to it, right? So come back. Okay, let me see.
Yeah, I'm
There you go.
I'm in now.
And now you can see it's not turning, so we know we're in. And so one of the things here is you'll actually want to bring that down into the wound, this piece, because that's going to allow you to drop the
Rock downwards.
rod down into position. Okay, so go ahead and grab that. We'll take some screws. Get started, just drop those down.
Amir, you make it look so easy. What system is this?
This is C-spine.
Is it C-spine?
Yeah.
Nice. So you did, is it 4 levels?
Yeah, 4 levels.
Okay.
Again, so many different applications for this.
And then can you, I don't know if you talked about this, but what are your tricks with the rod? Because like there, it looks like you're in the thoracic spine, right?
We're kind of at the thoracolumbar junction,
Oh, okay.
just because that's what was available to us.
So what do you kind of pre-bend it a little bit?
Yeah, I mean, you know, doing deformity is something that is probably worth an hour-long lecture in and of itself. You definitely need a pre-bent rod if you want to keep lordosis. You shouldn't really expect that the, go ahead, Mohammed. you shouldn't really expect that the rods are going to contour all that much. So you want to have the appropriate contour in there beforehand. Again, this is a lordotic rod, so I probably would have bent this a little bit in more of an S shape because it's at the thoracolumbar junction. And then that can make it a little bit tricky to get it to pass. You really want to, and sometimes a rotation medially laterally, as you're going in, you may come into the curvature and then turn it back the opposite way so that you're going through the curvature of the, and that's why I do these markings on the skin, to plan that out so I know what I'm going to be doing ahead of time.
And then how about, Amir, what do you do for the, so obviously you want this to fuse. Do you then decorticate before you drop the rod in?
You know, definitely not if it's a true percutaneous approach. There are times where I really like to do a Wiltsy, like if I'm doing a 5-1, I'll do an A-lift and a Wiltsy where I can then decorticate the facets and put in a nice, yeah, so that's final tightener there. So that I can put in bone graft and get a nice posterior lateral fusion. Most people that are doing purely percutaneous, like if you think about doing an ankylosing spondylitis case, those are probably going to heal because it's in the setting of fracture. Is there a counter torque? So when you're doing this, you want to make sure that you're, so come on out. But yeah, in the setting of fracture, you're expecting it to heal. Or if you're doing an MIS T-lift, you know, you are expecting that that inner body is going to provide a lot of the fusion mass as opposed to posterolaterally.
Mohammed, we're going to have to get you a membership to Gold's Gym.
I know I'm going to bring him to the gym with me after this. All right, that's good. And so taking this off, you really want to make sure that you're pulling back to disengage and then up. And then how do we get our towers off? Okay.
Great job, you guys. That looks terrific.
Oh, we do not have the tower breakers. So our patient is going to go home with these sticking out of the back.
Oh my goodness.
You can't just break them?
Amir can just break him with his one hand. Look at
So
that.
this is what happens when the rep does not bring the tower breaker. You just kind of break it off. Go that way. It's hard when there's no rod in there because they're not totally fixed.
Wow.
So let's get a shot, please. And let's slide a little bit, I think, north.
Let's get an AP and lateral. That looks good, Amir. Great job.
Yeah, thank you. So
Wow.
that's a little bit long.
Good job, Mohammed.
Thanks.
Let's come to an AP, please.
I think Amir can break that with like one finger. He's so strong. Wow, that looks great.
I think that one screw down at the bottom looks a little bit lateral. We were worried about that ahead of time. So would not want to accept that screw. But the rest of them look pretty good to me.
Looks great, you guys. Good job, Mohammed.
Thank you very much, you guys.
Thanks,
and,
Amir.
Appreciate everyone staying tuned.
Yeah.
To watch.